Hi everyone, this is Lolita. I'm the clinical pharmacist over at Rush University Internist, and I'm going to be talking to you a little bit about where the medications come into play, and being that there are so many medications available for the management of type 2 diabetes, how do we go about deciding what is the appropriate medication to start? So obviously the first line of therapy for patients with the first line of treatment for the majority of patients with type 2 diabetes is going to be metformin. When compared to other oral agents, no other oral anti-hyperglycemic is going to give you the same A1C reduction. So at its appropriate treatment dose of 2 grams daily, you can expect to see about a 2 to 2.5% A1C reduction with metformin. What further supports its use in patients as a first-line agent is the fact that it has a low risk, it doesn't cause hypoglycemia, it results in weight loss, or at worst it's weight neutral, and there have been studies that have shown that it's been beneficial and it may reduce cardiovascular mortality. It's very cheap, widespread availability, and it's easy to use. It's generally well tolerated, with your most frequent cited adverse effect being the nausea and vomiting, which will be subsiding once the dose is reduced. I'm sorry, not when the dose is reduced, but the nausea and vomiting will subside once the patient has been on the therapy for at least a week or two. So after A1C, so with the majority of patients, when an A1C is less than 9%, you can consider monotherapy of metformin at its targeted dose, 1,000 milligrams twice daily, with lifestyle management. And then you would obviously monitor your A1C after 3 months of monotherapy. For patients that have an A1C greater than or equal to 9% but less than 10%, or who may be resistant to start insulin from the get-go, you would consider dual therapy. Now, previously, the American Diabetes Association used to say that after metformin, all oral anti-hyperglycemics are second line, and you can choose one based on patient-specific factors. But they've changed their approach since the standards of care came out in January 2018. So after metformin has been titrated to the goal dose of 1,000 milligrams twice a day, and the A1C is greater than or equal to 9%, you really want to make considerations as to what agent you would choose based on if the patient has already clinical cardiovascular disease. So in patients that have clinical cardiovascular disease, you want to add an agent that's been proven to reduce major adverse cardiovascular events and or cardiovascular mortality. And the ones that have been shown the most promising at doing this would be liraglutide, brand name Victoza, so it's a GLP-1 once daily agonist, as well as empagliflozin, which is an SGLT2 once daily. In patients that do not have clinical ASCVD, you can add any second oral agent after consideration of your drug-specific effects and patient factors. So in patients that don't have any clinical cardiovascular disease, the things that you're going to be thinking about is what's the degree of hypoglycemia, what is the current renal and hepatic function, and is this medication even appropriate for this patient? Is this medication result in weight loss, or is it weight neutral? What are the other comorbidities present? In patients that have stage 3 or 4 heart failure, for example, a TZD would not be the appropriate option. In patients that have a previous history of pancreatitis, a GLP-1 or DPP-4 would not be appropriate. So taking into considerations those accounts, dosing frequency as well as cost is what's going to guide your decision making when we're dealing with patients without any clinical cardiovascular disease. And then obviously at that point, If your A1C is at target at 3 months, then continue to monitor it appropriately. If it's not at target at 3 months, then you can consider triple therapy, or at that point, it's probably a good idea the guidelines say you can consider triple therapy, but you can also have a good discussion about adding on a basal long-acting insulin. So triple therapy is going to be lifestyle management plus metformin plus 2 additional agents. And then that third agent is going to be primarily based on the drug-specific effects and patient factors. So again, what's the degree of hypoglycemia? What are the other comorbidities present? And probably the most important factor you're going to take into account would be what's the degree of A1C reduction that medication is going to give me. And then just kind of a clinical tidbit is, for every medication that you add on, you will not get the maximum A1C reduction that's typically available with that agent. So, for example, with metformin, you could typically see a 2 to 2.5% A1C reduction. A sulfonylurea, about a 1 to 1.5%. But if you added on that sulfonylurea after that metformin, that patient is unlikely to get that full 1.5% benefit. So it's typically right at the get-go, right when we're initially lowering A1C, that patients are going to get that biggest A1C reduction. If the patient fails on triple therapy, then it's really time to look at adding on or switching patients to insulin. So, per the American Diabetes Association, you really want to consider insulin in type 2 patients that have an A1C greater than or equal to 10%, any random blood glucose that's greater than 300, if rapid reduction in blood sugar is necessary. For instance, if you have a patient that was recently diagnosed that needs to go to surgery for whatever reason, or if there's obviously a hyperglycemic emergency present. For those patients who you deem that insulin is appropriate therapy, the management approach is going to be a little bit different than type 1 diabetes. Because you're assuming that type 2 patients, when they're initially diagnosed or put on insulin, have a little bit of residual pancreatic alpha cell function remaining, beta cell function remaining, then you're going to just give them a once daily basal insulin. So you could start that at either of a dose of 10 units per day or 0.1 to 0.2 units per day. We typically, in our clinic, start at a dose of 0.2 units per kilogram per day because it is more patient-specific and it takes into account the possibility of insulin resistance. The most common way to start a long-acting basal insulin is to start a once-daily glargine or detamir injection at a dose of 0.2 units per kilogram. However, if the insurance is prohibiting that, you can use the twice-daily NPH as your basal formulation. You would adjust it by 10 to 15% or 2 to 4 units once or twice weekly to reach that fasting blood glucose target of 80 to 130 milligrams per deciliter. And obviously, for patients that have hypoglycemia, it's even more pertinent to lower that insulin dose. So if the A1C is not at goal after 3 months of this therapy when the fastings have been controlled, then typically what we're going to do is add one rapid-acting insulin injection before the meal or add a short-acting GLP-1 receptor antagonist. So the GLP-1 receptor antagonists have been shown to be beneficial in reducing postprandial blood glucose sugars and resulting in clinically significant weight loss, as well as potentially having an effect on fasting blood glucoses as well. So they really are coming more into favor over adding on this one-time bolus insulin. However, if you choose to do that once rapid-acting insulin injection before the largest meal, we typically tell patients to take it at dinner, and we start it at a dose of 10% of the basal dose or just a blanket dose of 4 units. For the GLP-1 receptor antagonist, that's going to really be led by insurance and which specific GLP-1 agonist is really covered by that patient's individual insurance. You can also switch to a pre-mixed insulin twice daily, so that would be that NPH regular or NPH rapid acting mix of either 70-30, 75-25, or 50-50. So the most common ones that we're going to see is that 70-30. So given twice a day, once at breakfast, once at dinner, and it's going to have 70% of that dose be NPH. So provide that patient with approximately 10 to 12 hours of basal coverage, and then 30% of that dose is going to be their mealtime insulin, so they do need to be told to take it right when they sit down to start that meal. So just making a quick review over the hypertension guidelines for patients with diabetes. These really do kind of mirror the recommendations that were put out by JNC8 in stating that the primary method to determine what medication class is going to be appropriate for a patient to be initiated on is going to be based on two factors. One, not whether they have diabetes, but whether they have CKD or albuminuria present, and two, their race. So if albuminuria is present, that patient, even if their GFR does not suggest CKD, does meet criteria for CKD. So for those patients that have albuminuria present, then you would want to give them that ACE or that ARB to prevent that potential glomerular nephropathy from occurring. If that albuminuria is not present, then you really have the choice to give the patient an ACE, ARB, calcium channel blocker, or diuretic. And really what's going to be the driving force to tell you which agent to pick if albuminuria is not present is really going to be the patient's race. So in patients without albuminuria who are Caucasian, non-African American, any one of those medications would be appropriate. In patients that are African American, you would really want to avoid the ACE or the ARB if that CKD or albuminuria was not present, because you don't get the same degree of blood pressure reduction. So your first line agent would rather be a dihydropyridine calcium channel blocker such as amlodipine or a thiazide diuretic. So if the patient has not met the target, then you're going to, at your next visit, and they've been up-titrated to the maximum dose, then you can add an agent from a complementary drug class. So a good rule of thumb is your thiazide diuretic should never be more than the second medication you choose. So if that initial medication you chose in a non-African American patient was an ACE or an ARB, and they haven't achieved their blood pressure goal, then you would add on a thiazide diuretic. If you initially started a thiazide diuretic in a patient who was African American, then you have the choice to add on anything from the next three drug classes. And the reason that thiazide diuretic is so important to any hypertensive regimen is because there's synergistic effects, and it really does enhance the activity of other medications that are given to lower blood pressure. So really at any point, the thiazide diuretic should be that no more than the second medication added on, unless there are contraindications to its use. So with that, thank you for your time.